Good afternoon. Thank you for attending the presentation on multidisciplinary approach to advanced prostate cancer care. I'd like to thank the organizers of the ADME-Tech meeting for inviting me to give this presentation. Here are my disclosures. The objectives for this talk are to understand the clinical guidelines for states of advanced prostate cancer and discuss the treatments that are available for each of those states. Will then help develop a framework for multidisciplinary care of advanced prostate cancer patients based on the recently published AUA-SUO guidelines. The vast majority of men who are diagnosed with prostate cancer present with localized disease and will receive definitive treatment with either surgery or radiation with or without androgen deprivation therapy. Unfortunately, many of these men will have recurrent disease and require hormone therapy for prolonged periods of time, at which point many of those will develop castration-resistant disease and will require higher advanced systemic therapies. Now, the states that we'll be discussing are biochemical recurrence, metastatic hormone-sensitive prostate cancer, or MHSPC, non-metastatic castration-resistant prostate cancer, or NMCRPC, and finally, metastatic castration-resistant prostate cancer. For men with biochemical recurrence, we can use PSMA PET imaging if available, if there's PSA recurrence after failure of local therapy, as an alternative to conventional imaging, which would be CT or MRI and bone scan. Of note, patients should not be routinely initiated on androgen deprivation therapy, but could be offered observation or clinical trial enrollment. For men with metastatic hormone-sensitive prostate cancer, again, conventional imaging and or PSMA PET could be used. And in these patients, multiple trials have shown that ADT in combination with docetaxel and either abiraterone with prednisone or darolutamide are preferable treatments, and this is grade A of level of evidence. For men with non-metastatic castration-resistant prostate cancer, the options include apalutamide, darolutamide, or enzalutamide, along with continued ADT. And lastly, for men with MCRPC, again, conventional imaging or PSMA PET can be used ideally at intervals of 6 to 12 months. They should have continued ADT with any of the oral medications previously mentioned, radium therapy, or immunotherapy. Second-line chemotherapy can be used in the form of cabazitaxel. They can also receive PARP inhibitors, Sipuleucel-T, or platinum-based chemotherapy. Additionally, recent data has shown that lutetium-617 can be provided for patients with progressive MCRPC who previously have received docetaxel, an androgen pathway inhibitor with a positive PSMA PET. Now, the rationale for urologists is relatively simple in patients with advanced disease, in that many of them have encountered a urologist at some point during their disease journey, either through biopsy, surgery, or during follow-up for PSA. Additionally, urologists are familiar with and treat many of the post-treatment complications that can be seen. Many patients will express a desire for continuity of care, even if there is disease progression, and a urologist can manage sequelae of advanced disease, such as outlet obstruction, upper tract obstruction, or hematuria. Now, the partnerships that will be needed in the multidisciplinary clinic will be multiple resources, and particularly you can use advanced practice nurses as your partners within your clinic. They can be a resource within the clinic. They need to be familiar with the clinical guidelines and advances in therapy. And they can communicate with the MD, who is their partner, particularly if they are practicing at a different site. You also need to partner with a specialty pharmacy who can not only assist with drug-drug interaction, but also communicate with foundation funders and company-specific programs in order to lower costs. Speaking of costs, we can, as urologists, help mitigate financial toxicity by seeking out programs to assist patients with the cost of care. In this study performed out of Penn and Vanderbilt using the Mark Cuban Cost Plus drug company, it shows a significant decrease in the cost of abiraterone, which is a medication available for men in advanced prostate cancer, compared to the 2020 Medicare costs as seen on the far right. So what can urologists provide in terms of therapy for patients with advanced prostate cancer? We can provide injectable or oral ADT. We can prescribe second-line oral therapies. We can be a resource for immunotherapy in the form of sipuleucel T. We can perform surgical castration. And in some practices, PARP inhibitors or docetaxel are administered, but for the vast majority of patients, this comes through medical oncologists. So who is on your internal team? As I mentioned, an APP as well as a lead nurse, especially pharmacy. You need access to a tumor board to discuss complex patients with other urologists, medical oncologists, radiation oncologists, and nuclear medicine. You need industry partners, particularly if you're going to be a lead on any clinical trials. And then you need access to apheresis and infusion units, either for sipuleucel T or infusion of chemotherapy or PARP inhibitors. The members of the multidisciplinary team include medical oncology and radiation oncology, nuclear medicine, specialty pharmacy, medical genetics, and we'll speak more about the role of genetic testing in these patients later in the talk, an apheresis location, and very importantly, access to palliative care and hospice. If you'll note in all of the guidelines for patients with advanced symptomatic disease that is progressing rapidly with limited lifespan, we should actually de-escalate in potentially toxic therapies and lean on our palliative care and or hospice colleagues for comfort care. Now let's review some of the data that led to the approval of many of the medications that are used in the various states. For patients with mCRPC, the utilization of sipuleucel T was approved in 2010 via the IMPACT trial. There's a 22% reduction in risk of death among men who receive sipuleucel T versus placebo. And importantly, what was found more specifically in men with a lower PSA below the median of 22.1, you actually see a 49% reduction in risk of death in this post-hoc trial. Now, importantly, this study was not powered to detect a difference within groups, and these were not randomized groups. However, it appears that treatment earlier in disease progression appears to have the greatest survival benefit. In the same study, Black men were shown to have even greater improvement in survival compared to white men, again, in PSAs less than 26 and even greater in PSA of less than 7.5. The Cougar trial led to the approval of abiraterone in metastatic prostate cancer with a 25% reduction in risk of death. Enzalutamide and mCRPC, again, with a significant reduction in the risk of death and increased overall survival. In hormone-sensitive metastatic disease, two trials, Titan and Arisens, showed an approximately 30 to 40% reduction in risk of death for apalutamide and darolutamide in this state. For patients with symptomatic bony metastasis without visceral disease or significant lymphadenopathy, radium-223 is an option. This radium produces high-energy alpha particles that cause double-stranded breaks in DNA. If you remember from your high school chemistry, radium and calcium are in the same family, and radium seeks out bone in a similar way to calcium. Radium was approved using from the Alsimca trial with a 30% reduction in risk of death and greater than 3-month increase in overall survival. The recent VISION trial is what led to the approval of lutetium PSMA treatment for mCRPC with a significant reduction in risk of death of 38% and prolongation of survival. The NCCN guidelines have stated that germline testing should be performed in men with metastatic prostate cancer, germline and or somatic testing, and this can be done by various companies. The genes of interest in this disease include BRCA1 and 2, ATM, PALB2, and others. The rationale for getting genetic testing is that there are certain treatments that are available for men who have mutations in particular genes. In particular, the PARP inhibitors are used in MCRPC. We know that up to 30% of men with MCRPC harbor deleterious DNA damage repair gene mutations, most commonly in BRCA1 or 2 and ATM. Olaparib and rucaparib have been approved for men with DNA damage repair mutations following androgen receptor-directed therapy or after taxane-based chemotherapy treatment. So in summary, patients with advanced prostate cancer have several options for treatment that are relatively well tolerated, though optimal sequence has not been determined. A successful multidisciplinary clinic provides the best opportunity for patients to achieve a balance in management with quality of life. As we described here in this talk in detail, there are multiple clinical trials available for patients in these states, and we should continue to enroll patients to give them the best chance at improvement in survival while maintaining quality of life. Thank you very much for your attention and look forward to questions.